I'm Dr. Jack Bert. I'm an adjunct clinical professor at the University of Minnesota in Minneapolis, Minnesota. I am the developer of the Cartilage Restoration Center of Minnesota and a member of Minnesota Bone and Joint Specialists. I've been an orthopedic surgeon in practice for about 35 years in Minnesota. I decided to offer regenerative medicine to my patients when, after doing over 4,000 total knee replacements, I realized that up to 20% of patients that have total knee replacement are unhappy with their results. This has been published in over 6 studies now in the past 2 to 3 years. There's a huge group of patients between the ages of about 30 and 65 that don't have severe enough arthritis to warrant a total knee replacement, and they do need something in between to try to stall the inevitability of putting metal and plastic in their knee. Thus the logic of using drugs like viscosupplementation, PRP, and stem cells. It appears from our literature now that stem cells seem to be the best form of treatment at developing new cartilage surfaces on the end of joints that have arthritic changes. The reason that you use stem cells derived from bone marrow is that they have the highest concentration of stem cells per milliliter. So the truth of the matter is, the more stem cells you have, the better off you are, and the less white blood cells you have, the better off you are. So the actuality and fact situation is that when you take stem cells from bone marrow, you get the combination of high concentration of stem cells and a lower concentration of white blood cells. That's not true in other biopsy sites. So stem cells are ubiquitous. They're omnipresent throughout our body. They can come from amniotic fluid, they can come from blood, they can come from synovium, they can come from bone, and they can come from fat. So the source of the stem cells from bone really is the best, as previously stated. And the advantage of using a stem cell is that it tends to transform itself into adjacent cartilage when you put it next to cartilage, and thus the advantage of implanting it or injecting it into the knee. You can actually physically implant it. The truth of the matter is that's a very long operation. It does involve opening up the knee, and the success rates are variable in terms of implantation versus just injecting it. So the obvious advantage of point-of-care therapy is that you can take the patient into a procedure room, do a very minor anesthetic, both local and perhaps a little bit of blood-borne anesthetic. In other words, just a short-term injection, like if you were having a colonoscopy, just to relax the patient, so that they're just having a little less anxiety during the aspiration. After about 30 minutes, you can literally take that aspirate, spin it down, and inject in the knee. So the whole process takes about 40 minutes to do. And that's a huge advantage to the patient because they can come in, get it done on the same day. So after you do the injection, the patient will feel the benefits from the therapy anywhere between 6 weeks and 6 months. The truth of the matter is it probably takes anywhere between 3 and 6 months for the stem cells to really grow adjacent to the existing cartilage and over the surface of the bone. So the truth of the matter is it's probably closer to 6 months before the biology catches up with what they're feeling, but they may feel benefits earlier. The FDA doesn't have an issue with it. The problem is the insurers don't pay for it. Because the insurers are reluctant to pay for any new type of treatment unless you have long-term studies that have been made available to them. So the FDA has approved this without question, and I think it's a benefit to our patients. So platelet-rich plasma, PRP, and stem cells are totally different animals. We're taking the PRP from the blood and we're spinning it down, and the concentration of stem cells that you're going to get is much, much lower. So that's the advantage of using stem cells. Plus the content of white blood cells in PRP is higher. We know for a fact that white blood cells tend to reduce the amount of growth of cartilage wherever it comes into contact with that bony surface. So that's the advantage of stem cell therapy. So the orthopedic conditions that stem cells treat would be early arthritis, predominantly. The advantage of using a stem cell when there's still a little cartilage left, when there's not a massive amount of raw bone, is that it can attach to the surrounding remnant cartilage or existing cartilage to grow into that defect where there's raw bone. Ideally, it's probably not going to work very well in a patient who's severely arthritic bone-on-bone collapse. However, in those patients that are between 30 and 65 that don't have significant bony collapse, which is the highest rate of growth of arthritis of the knee right now in the U.S., it's extremely beneficial. There are many studies that I've had the opportunity to review as being the past president of the Arthroscopy Association and being involved with all the courses like the one I'm at right now in Dallas, where we have about 350, 400 orthopedic surgeons learning arthroscopic techniques, is that we know that if we take even a minor amount of meniscus or cartilage out of an athlete in their 20s or 30s, within 10 to 15 years, they're going to develop some early arthritis. So that's the group we're going after. And since so many kids today are playing sports at a younger age, the incidence of taking cartilage out of the knee is accelerating rapidly. So we've got a massive group of people who are developing arthritis in their 30s, 40s, and 50s. That's why this therapy is so critical at this point in time in the United States and really throughout the world. So the ideal candidate for stem cell treatment is somebody who has early arthritis, and it'd be ideal to do it at least every 6 to 12 months, really for the rest of their lives. As I stated previously, what we're going to have is this massive group of patients with early arthritis that's growing exponentially in that 30 to 65-year-old age group. The theory being, if you could get new cartilage to form on the end of the bone, you may never need a total knee replacement. And that's why this is such a critical modality of treatment. So adult stem cell therapy has been shown to be helpful, actually. There's some argument and controversy regarding this for things like rotator cuff tear for injecting into ligaments. It seems to stimulate healing much quicker. So for example, I take care of a couple of professional athletes, and I've injected visco supplement. There's one I'm debating doing stem cells right now to try to get them back quicker, but these individuals, both collegiate, professional, even high school athletes that develop problems with ligaments, early arthritis, which incidentally, there's 4 published studies that show that patients who have meniscectomies as teenagers develop arthritis in their 20s. So about 20% of patients, when you're doing a scope, you see some arthritis already starting to develop, which is really kind of tragic. And so you have to be aggressive with those patients as trying to find some sort of chemical injection that will help them and not develop significant arthritis in the future and actually reverse it. So the purpose of looking at this very carefully is to show that stem cells are going to keep cartilage from getting worse and probably rejuvenate it. There are some studies now showing that some of the visco supplements, PRP, and stem cells actually increase the amount of proteoglycan in the cartilage cell. These are experimental studies, pardon me. But the good news is that if that's true, we're going to actually reverse this cascade of events occurring where the cartilage gets worse. It's going to actually get better. And that's our goal. Again, to try to avoid putting metal and plastic in their knee in 20 years if you can catch them early enough. So again, I think that if you look at the literature as clearly as you can, look at the literature from Italy, from Germany, where they've been implanting stem cells for over 4 to 5 years, the results are pretty impressive because they're getting 70 to 80% response. Are they all getting 100% hyaline cartilage in their biopsies? No, but it sure is a heck of a lot better than what we've had in the past. So there's a lot of research being done now on reducing oxygen tension in the stem cell transplants. That seems to be where the answer is going to be. And at some point in time when that is answered over the next 2 or 3 years, I think this is going to be a very commonplace procedure in patients with mild to moderate arthritis. So again, patients who get stem cell therapy tend to do better. They're happier patients. They're trying to avoid the inevitable total knee replacement. They get back to more normal activity without having metal and plastic put in their knee. And that's really your ultimate goal. I've reviewed the literature. I've done PRP. I've done viscosupplementation. I'm excited about beginning to use stem cells because I think it's the next step in progression of giving better conservative care for patients to avoid having to do total knee replacement. And so I have several candidates right now that are ready to do it. I have some professional athletes. I have a lot of college athletes. But more importantly, and in the greatest group, it's those patients in their 40s and 50s and early 60s who have mild to moderate arthritis that simply don't want to go through a massive operation with only an 80% success rate, which is total knee replacement. So I'm really excited to get started on this journey, and I will look forward to giving you success stories in the future.